Community-acquired pneumonia. 71-year-old Hank is admitted to the primary care clinic because he had had fever for 2 days. His sister Helen says he is shaking with chills, with a productive cough, and he cannot lie down to sleep because he can't stop coughing. After he is examined, he is diagnosed with CAP and admitted to our floor at 11:30 for further assessments.
Hi, my name is Najma, and I'll be presenting the assessment portion of my project. So as we're looking at the subjective data, so the initial assessment of it, Hank is experiencing hives, he can't really lie down, chills, productive cough, and pain on his left side. So when we're looking at the progress of his subjective data, he's denying dyspnea, as well as he still complains of pain on his left side. But a lot of his other symptoms have left, so there is definitely progress there. When we're looking at the initial assessment of his objective data, these are his vitals, as well as there's decreased breath sounds, and we can hear coarse crackles left side anteriorly and posteriorly. We're also seeing that his nail beds are dusky on his fingers and his toes, as well as his cough is not productive, with rust-colored sputum. When we're looking at the progress of his objective data, from the vitals, we can definitely tell that the heart rate, the respiratory rate, as well as his temperature have gone down. There's no signs of any kind of apparent distress. And when we're listening to his breath sounds, we can hear it on the lower lobe anteriorly, not posteriorly anymore. We also can see that his cough is productive with yellow colored sputum. When we're looking at his nursing health history, he does have a history of CAD as well as an MI. He's never received the flu vaccine, as well as he does report getting hives, so an allergic reaction after taking an antibiotics pill. Now we're moving on to patient's records. So we're looking at his lab tests, his microbiology, as well as his social history and aspects of that. When we're looking at consulting support persons, we're also talking about house help. So maybe having a PSW at home to help him with chores and stuff, since his sister is the only sole provider to help him out. And maybe visiting some support groups, to see other people going through the same issues that he's going through, to make him more stronger and not feel like he's alone in the situations. As well as when we're looking at consulting health professionals, we're talking about consulting physicians, dietitians, social workers, therapists, nurses, etc.
Hi, my name is Destiny. I'll be talking about the diagnoses. So first, we just want to talk about the rust-colored sputum and the yellow-colored sputum as well. So basically, this was to be an indication of a bacterial infection, which is commonly found in community-acquired pneumonia. We also want to look at the yellow-colored sputum, which indicates that there's still an infection, but the body is trying to fight it off, but explains the elevated white blood cell count. We also want to look at his sputum culture. So the more of these epithelial and neutrophil cells would determine the quality of the sputum. So because of it, it would be like a thick secretion that's coming out of his lungs. So it would indicate the productive cough as he's trying to clear out his airway. So now we just want to look at impaired gas exchange related to fluid and exudate accumulation. So in impaired gas exchange, oxygen is not able to enter the blood from the lungs. So because of that, the alveoli is inflamed, which would have like a fluid accumulation, exudate accumulation, which would be an indication of more of a productive cough, and the coarse crackles, which we found on auscultation. So there'd be adventitious sounds because of the fluid accumulation, because of the impaired gas exchange. We also just want to look at now ineffective breathing patterns related to acute pain due to infection. So upon assessment, Hank was complaining about left-sided chest pain as he coughs. This is because of his bacterial infection, because of the fluid accumulation in his lungs. As he said, he was trying to cough it out, so it may hurt on his left side. We also want to talk about the restlessness because of his productive cough as well. So because he's coughing so much, it's hard for him to sleep. And we also just want to talk about his respiration rate. Because he has all this fluid accumulation, he will be having some rapid shallow breaths because of the accumulation, like I said before.
Planning goals and outcome. The overall goal for patients with pneumonia is to have clear breath sounds with normal breathing pattern, normal chest radiograph, no signs of hypoxia, and no complications related to pneumonia. In regards to our patient's airway clearance, our goal prior to discharge is that he could identify the need to clear his airway and be able to demonstrate it. Our short-term goal is to increase his oxygen saturation above 95% and see the absence of cyanosis. In regards to his gas exchange, we would like to introduce him to a respirologist or pulmonologist to treat his lung ventilation and the oxygenation of his tissue. We would also like to see the return of the baseline of his ABGs and removal of respiratory distress, such as his coarse crackle from his lower left anterior lobe. In regards to his breathing pattern, along with the respiratory therapist, our short-term goal is to regulate his respiratory rate between 12 to 16 breaths per minute, or his baseline, and our long-term goal is to maximize his lung expansion to supply the body's demands. In regards to his pain, our goal to reduce his pain scale between 1 to 3, and that he so express relaxed habits such as sleeping through the night, lack of pain expression, and participation in balanced daily activities. In regards to his diet and lifestyle, our goal is to involve a social worker to help him cope with his losses and his condition, as well as speaking to a dietitian about eating healthy habits. Prior to discharge, Hank is ready when he is able to understand his condition, transmission, disease process, treatment, and how to prevent it from recurring again, as well as medication knowledge and the importance of follow-ups. Here are the healthcare provider that are part of Hank's care.
Implementation. So the first implementation or intervention is the semi-Fowler's position. The second one is the good lung down position, which is when the unaffected lung or the good lung is placed down in the lateral position to achieve maximum lung expansion and better oxygenation. The third intervention is deep breathing exercises, which is when we provide patient education on deep breathing exercises to prevent atelectasis, which is the complete or partial collapse of the lung. The fourth intervention is coughing techniques, which is when we provide patient education on coughing techniques to mobilize secretions. So examples of those would be huffing and splinting. The fifth intervention would be turning. Sixth intervention would be the use of the incentive spirometer. Seventh intervention is to promote exercise, because exercise and early ambulation are encouraged due to the augmentation of bronchial hygiene. The eighth intervention is promote proper health habits, because this helps the patient maintain the natural resistance to infecting organisms and prevent a relapse. So an example of that would be to increase fluid intake to 1.5 to 2.5 liters per day.
The ninth implementation is aspiration prevention, meaning assisting him with eating, drinking, and taking medications to prevent aspiration, as well as keeping him in an upright position when eating and cutting up food into smaller pieces. The 11th implementation is to avoid over-medication, especially with opioids, because it could cause depressed cough reflex and accumulation of fluid in the lungs. The 11th implementation is prescribed medication, and the 12th is patient education on medications. It's also important for vaccine availabilities, which should be discussed with their healthcare provider. And it is also important for us to inform the patient regarding the importance of receiving the influenza and pneumococcal vaccine.
I'm going to be talking about evaluation. So I think all of the interventions that are already set are realistic and doable because he can do these at home. But I think that we don't have enough objective data because we're talking about lung capacity, and things like his height, his weight, and his age are kind of ambiguous. So they haven't really been said or disclosed in the case study. So when it comes to the care plan evaluation, it's in 3 steps. So the first step is going to be follow-up. I think he should come back after 1 to 2 weeks or when his medication course is over, because it's important to see if he's adhering to the original plan or it's his adherence that is affecting the outcome of our plan. And then also, I think we should do a reassessment. So like our classic head to toe. And then we should also do things to check his lung function, like using an incentive spirometry. And if you look in the corner, there's a chart that talks about his age and his height to see approximately what his lung capacity should be. Another way to check his lung function would be doing a 6-minute walk with a pulse oximeter to see how his O2 saturation fluctuates while he's doing daily tasks. And then lastly, I think we should also look into his lab values, because if everything was in normal range, we could just modify it a little bit just so it's easier for him to adhere when he gets home. Also, there are community systems like volunteer services to help him with small things like groceries, support systems that can help him because maybe that's what's causing his inability to take care of himself, but also habit specialists that help you develop healthy habits, as well as meal services so he can have access to healthy meals. Then we're also talking about the social deterrents of health, things like income and social status. Like we don't know if he's retired, if he has a pension, how is he paying for bills? And then also his physical environment, because it keeps on being talked about, but we never really know how bad it really is. And then lastly, his social services and coping skills, because he only talks about his sister being his only form of support, and also how he's coping with his wife's death. And I think that's everything for me, and I think that's everything for the case study. Thank you and have a good night.